whether the patient needs stress ulcer prophylaxis or not, because there is a criteria for stress ulcer prophylaxis, and we as being pharmacists must know that. So whenever you receive a prescription for order verification and you see omeprazole in it, review the patient and check for the need of stress ulcer prophylaxis, because in most of the cases we do not need it, and we are just giving the drug without its need. So whenever we're reviewing a prescription, we must check for the stress ulcer prophylaxis protocol. Check if the patient has any nausea or vomiting, if he is on any antiemetic. Abdominal imaging often helps you to narrow down your diagnosis and to look for the source of infections. A very important thing is also to notice that if the patient, what kind of feeding on the patient is, because it helps you to find out or to point out the interactions with the drugs, as there are many drugs which have interactions with the food. For example, if the patient is taking warfarin and is also having a very green leafy enriched diet, so there is a possibility that vitamin K and the leafy vegetables, it might interact with the warfarin, and it increases in the level of, it interacts with its efficacy. Also, there is a very important interaction of tetracyclines with calcium containing food. So whenever any patient is taking tetracycline and in his food there is yogurt or milk, we must point it out, because the calcium enriched food, they're going to bind with the tetracyclines and they won't let the tetracycline absorb into the gut, and this is how we won't get the effect of the drug. So whenever you're reviewing a prescription, you must also have a sound knowledge of the drugs that interact with the food, and give instructions based on your expertise, that whether you have to give the drugs separate or apart from the food. Also check for the caloric requirement of the patient, and this is also very important whenever we're preparing intravenous feeding. Next is the urogenital. It is a very important aspect as well, because all the medications, they have to be adjusted on the basis of renal functions. So we must know the renal function status of a patient, and whenever we're reviewing the patient, the first thing you should do is check for the hepatic and renal function status. Check the RFTs, and not just the serum creatinine, check the urine output of the patient as well. We must always keep in our minds that we're not only treating patients based on the labs or based on the numbers that the patient is giving. You have to always see the patient as a whole, and this has to be our approach all the time, that we're seeing the patient as whole. So look for the creatinine, calculate the creatinine clearance, and also look for the patient urine output, and based on the urine output and the RFTs, adjust the doses accordingly. Like, you have to adjust all the doses of all the medications according to the renal and the hepatic function. So whenever you're reviewing the patient, you must have a sound knowledge of their hepatic and their renal status, and it is very important for the dose adjustments. Also, a very important thing to look for it, that if the patient has any folate in place and it's not needed, so it can be a source of infection as well. So look for it as well. Assess the fluids and electrolytes in the patient. Electrolytes are very important whenever, they're also important whenever you're giving drugs with them. For example, if you're giving amphotericin, you must know what is the status of serum potassium. If you're giving any diuretics like spironolactone, you also have to look for the electrolytes as well. So assess the need of any IV electrolytes replacement in the patient as well, and then review and optimize your prescription accordingly. So after urology, after genitourinary, the hematology comes. In the hematology, there is also a new concept of anticoagulation stewardship. And anticoagulation stewardship is a systemic approach which aims at optimizing the safe and effective use of anticoagulant medications, which includes heparins and low molecular weight heparins and 2X. So whenever you're giving the anticoagulant medications, must know the monitoring parameters. For example, if the patient is on warfarin, we need to monitor the INR of the patient. If we're giving the patient heparin, we need to monitor the avidity and anti-10A levels of the patient. So whenever the patient is on anticoagulation, must know what we need to monitor with the anticoagulation in order to prevent thrombosis and bleeding simultaneously. So it is our duty to look for it. So in the hematology, you see all the drugs which act on the heme aspect of the body, and if the patient is on any anticoagulation, look for the doses. Are the doses adjusted based on the patient body weight and its hepatic and renal status? And look for the monitoring parameters, which are usually APDT, INR, and we have also anti-10A levels in the body. Now, being a clinical pharmacist, there needs to be a checklist in the head of every pharmacist for three main parameters: interactions, therapeutic drug monitoring, and ADR monitoring. So these are the three parameters or three key things that every pharmacist should have in the back of their head. The first being interactions. So after you have completely reviewed a patient, after you have gone through the head to toe approach, you have systemically reviewed the patient and you have optimized the prescription based on your expertise, look for the interactions in the prescription. Always look for them. And the interactions, they are of mainly of two kinds. They can be pharmacokinetic, they can be pharmacodynamic, and it's a whole another topic. I won't go into the details because it will go beyond the scope of this presentation, but look for the pharmacokinetic and pharmacodynamic interactions that it may have, because there are many interactions, and interactions can happen at the drug absorption level, at the level of drug distribution, metabolism, or excretion. So always look for them. Also look for the drugs which have the synergistic effects or the drugs which can have antagonistic effect. For example, if you're giving a patient fentanyl or nalbuphine, they're both opioids, they're both painkillers, but they have an antagonizing effect, and the patient won't have a relief in their pain because they have antagonistic effect. And if you do not have the sound knowledge of your drugs, you cannot treat them. So always look for the interactions in the prescription, and do not complete it. Like, your prescription review doesn't complete without looking for the drug interactions. After interactions, there comes a therapeutic drug monitoring. It's also
Uh,
another complete
Ma'am,
G.
sorry for the interruption. Reminder for time limitation. Can you
Okay,
please
thank
cover
you.
it?
Thank you. I'm just
Okay,
wrapping it
thank you.
up.
Okay.
So therapeutic drug monitoring, it involves the measuring the drug concentrations in their plasma, and to optimize the medication dosing. So whenever you're giving a drug, you must know that there are certain drugs that need therapeutic drug monitoring, and if you're not monitoring the levels of the drug properly, you're not treating the patient rightly. So there are some examples of drugs that needs therapeutic drug monitoring. For example, aminoglycosides, glycopeptides, and others, an antifungal voriconazole. So these are the drugs that needs therapeutic drug monitoring. These are some examples. You have to individualize your need, and whenever you're reviewing the prescription, look for them. Look for the drugs that need therapeutic drug monitoring, and send for the levels of those drugs. Last but not least, adverse drug reaction. So whenever you're giving any drug, look for any ADR monitoring that the drugs requires. And this is how you complete your prescription review. You start with the head to toe approach. If the patient is on antibiotics, that should be your priority. Like, optimize the antibiotics, then have a systemic approach. Go from head to toe. Start system wise. Start from the CNS and CVS, GI. Review each system very keenly, and after that, you look for your any interactions, any therapeutic drug monitoring, and last, you see for any adverse drug reaction monitoring. So this is how you complete a prescription review whenever you're in a hospital, sitting in your pharmacy, and you have a prescription for order verification. So we'll go back to the case that we from where we started. So in this case, as we can see that the patient is morbidly obese, he is weighing 110 kgs and he was only getting vancomycin 500 mg 48 hourly, which was not the right dose for the patient. So since he was on vancomycin, but he was not being treated because the dose was not right. So here you have to intervene and you have to give it at the right dose. That the vancomycin, it is usually given in 7.5 to 10 mg per kg. So first you will make the dose right, and then we'll look for the therapeutic drug monitoring of the drug. After that, you see that we have the cultures, they have reported MRSA. So we have a culture. So we will narrow down the antibiotics. So meropenem and levofloxacin, there is no need for both of these drugs. So we will discontinue meropenem and levofloxacin and we'll continue with the vancomycin only. And because vancomycin, it needs therapeutic drug monitoring, will measure the levels of vancomycin in the blood. After optimizing the antibiotics, looks for the interactions. As we can see that haloperidol and levofloxacin, they both increase and they both prolong the QT interval in humans. So we have to look for the QT. We'll order the ECG of the patient, look for the QT, and optimize the drugs accordingly. Also, the patient is on GI omeprazole injection. So we will look at whether the patient really needs a stress ulcer prophylaxis or not. So this is how we will optimize the prescription of this patient. In closing, let's remember that comprehensive medication management is vital for patient safety and well-being. And thank you for your attention. And thank you
Thank you,
very much.
Ms. Zainab Babar.
Thank you very much.
Okay. Your presentation was very informative, engaging, and thought provoking. Participants, reminder for you, you can leave your queries in the chat box so that we can be answer them in the end of session. Okay, so let's head on towards our next speaker, Dr. Mashal Zehra. She is working as a clinical pharmacist since last 4 years at the Indus Hospital and Health Network, and specifically for Obgyn and neonatal setup. So over to you, Miss Mashal.
Assalamu alaikum, everyone. First of all, so sorry for the disturbance in the
Alaikum assalam.
chronological order. Let's proceed with our presentation. Okay, as you all have already gotten the insight regarding the clinical output of doing the CMM, firstly, let's know what basically how the pharmacist plays the role in it. As we all know, we are the custodian of the drugs. We know the very well information about what the drugs do with the body and what the body does with the drug. So we can optimize the patient plan accordingly in order to bring the maximum output of the drug, ensure the patient satisfaction and as well as the satisfaction. Now, what usually we face the challenges in our healthcare system, we can say, अगर हम बाहर community pharmacy या general medical store की बात करें, so we do not have that much pharmacists over there. Without even asking for proper information, उन्हें medication दे दी जाती है. अगर हम हॉस्पिटल सेटअप की बात करें हॉस्पिटल सेटअप usually there is no as such concept of reconciliation. There are very outdated system. Pharmacists इतने ज्यादा appointed नहीं है और जहाँ है वहाँ बहुत अच्छा काम हो रहा है. Now, before understanding, मतलब आप लोग को clinical output तो समझ में आ गया, but as I was going through the chat, most of the people over here are either in the initial career of their pharmacy or either they are undergraduate students. So I'm just going to give you a short insight into my career. जो basic तरीका होता है आप पेशेंट को कैसे अच्छे से आइडेंटिफाई कर सकते हैं या उसके बारे में head to toe सारी information ले सकते हैं. That is the well-known SOAP notes proper way. Now, what is the SOAP note? S stands for subjective, जिसमें आप patient की chief complaint, history of present illness, current medication and allergies. ये आप document करेंगे. O stands for objective, in which you are going to document the vital sign, the physical examination, lab data and imaging. A stands for assessment. This basically bases upon the combination of the subjective and objective outcome in order to define a diagnosis and come towards a differential diagnosis. P stands for plan. अगर हम physician के level पे बात करें तो plan में physician would document whole plan के आगे उनका क्या proceeding करवानी है, test क्या करवाना है, क्या laboratory और भेजना है, क्या medication है. अगर हम pharmacist perspective की बात करें तो we are going to document all the medication which a patient is being prescribed and what further intervention we would like to do. In order to get the understanding about how soap notes are processed and done, here I have mentioned a case. There is a 32-year-old female married for 10 months, primary gravida, at 39 plus 1 weeks. She comes with the complaint of lower abdominal pain since last night, having history of diabetes on glucose 500 mg/d. She is TB positive, taking RHZ 2 tablets once a day. Patient has known allergy to tablet diclofenac sodium and ferrous sulfate. The home medication other than listed above are domperidone, folic acid, calcium carbonate, and syrup maltopur. As you can see, I have listed the whole S portion of the soap notes. Then I've come towards the objective. In objective portion, you can either mention all the lab values or you can just mention the lab values which are necessary as per your medication and your guidelines. Okay, I have just mentioned the CBC and the ref notes. The third is the assessment. The assessment diagnosis, yeah, admitting diagnosis is the progress of labor. Now, what is the plan? As you can see, I have listed the medication which were being prescribed to this patient. That is ferrous sulfate, folic acid, calcium D, suppository diclofenac, capsule omeprazole, and tablet RHZ. अब आपको clinical insight तो ज़ैनब बता चुके हैं, तो I guess most of you people would be having the idea कि हम कैसे intervene करेंगे. जब हमने प्रॉपर पेशेंट को असेस कर लिया है तो अच्छे से इंटरवेंशन करने की आसानी होगी. अब इसमें सबसे पहली चीज क्या मेंशन थी हमारी सब्जेक्टिव में कि पेशेंट फेरस सल्फेट से एलर्जिक है. तो पहली इंटरवेंशन हम क्या करेंगे कि हम फेरस सल्फेट को स्विच करा देंगे आयरन पॉलीमाल्टोज पे बिकॉज द पेशेंट हैज अ नोन एलर्जी. सेकंड क्या है, हमें पता है डिक्लोफेनिक से पेशेंट एलर्जिक थी तो हमने पैरासीटामोल पे स्विच करा दिया. एंड थर्ड हमारे पास क्या है कि हमें पता है कि रिफेम्पिसिन और ओमेप्राजोल का इंटरेक्शन होता है साइटोक्रोम 3A4 के थ्रू. तो वी आर गोइंग टू आइदर चेंज द फ्रीक्वेंसी ऑफ ओमेप्राजोल और वी आर गोइंग टू स्विच टू अनदर क्लास दैट इज फेमोटिटिन. आई होप अब आप लोगों को आइडिया हो गया कि once you will document the soap note, you'll have the idea how to go through the patient profile, then you'll be able to assess the drug and the interaction and other stuff to intervene. अब आ जाते हैं types of intervention. There are multiple types of intervention as defined by ASSP. We have adapted some variable at our hospital setup. Now, number one is CS based. What is CS based? CS is culture and sensitivity. अगर हम किसी patient को antibiotic दे रहे हैं तो खास ख्याल रखना होता है that we need to send the culture and sensitivity report. It is a test जहाँ पे either swab या fluid XYZ कोई चीज हम culture के लिए भेजते हैं और उसमें जो specific bacteria होता है उसके against sensitivity or resistivity of the drug are mentioned. So we have to check that the antibiotic which has been prescribed either it is sensitive or not. If yes, it is, then we are going to continue the same. If not, then we are going to switch to the another drug. Interaction, as we all know, there are three types of interaction, either drug-food, drug-drug, or drug-disease. Duplication of class activity. For example, a patient has been already prescribed with meropenem or उसके medication order में peptaz डाल दी गई है. So there is no need of these two antibiotics because they both have same spectrum of कवरिंग ऑफ द बैक्टीरिया. फिर हम आ जाते हैं डुप्लीकेशन ऑफ मेडिकेशन ऑर्डर. इसकी एग्जांपल ये यूजुअली अक्सर ये होता है कि भाई रात को पेशेंट को एम्लोडिपिन 5 mg ओडी चल रही थी, सुबह में मॉर्निंग राउंड हुआ, द डोज वाज इंक्रीज टू 10 mg बट द प्रीवियस डोज वाज इन स्टॉप्ड इन मेडिकेशन ऑर्डर. तो दोनों मौजूद होते हैं. तो दैट इज कॉल्ड डुप्लीकेशन ऑफ द मेडिकेशन ऑर्डर. देन वी हैव रॉन्ग रूट, रॉन्ग फ्रीक्वेंसी. Therapy modification, we sometimes modify the therapy based upon the PKPD. Then we have switching to alternative, knowing our economical condition. We multiple time we face such condition जहाँ patient जो medication ले रहे होते हैं वो हमारे पास available नहीं होती है, तो हम alternative पे switch कराते हैं. Then we have unnecessary drug. For example, if a patient who is admitted complains about diarrhea or let's say nausea, we prescribe the patient with domperidone. Once the nausea has been subsided, we need to stop the domperidone. We do not need to continue it. So इस तरह की इंटरवेंशन हमारी अननेसेसरी ड्रग में आएगी. हेपेटिक डोज एडजस्टमेंट में हमारे पास आ जाएगा किसी पेशेंट का लिवर कॉम्प्रोमाइज है, तो जो ड्रग्स जिनकी हेपेटिक क्लियरेंस है या वो हम नहीं देते उन्हें हम एडजस्ट करेंगे। रीनल डोज एडजस्टमेंट में अगर क्रेटिनिन कॉम्प्रोमाइज है, क्रेटिन क्लियरेंस हमारा बढ़ा हुआ आ रहा है, कम आ रहा है, तो हम जो है उसके हिसाब से एडजस्ट करेंगे। कॉन्ट्राइंडिकेशन में देयर आर मल्टीपल कंडीशन, फॉर एग्जांपल G6PD डेफिशिएंसी है, मिस्थीनिया ग्रेविस है, तो उसमें कुछ ड्रग्स जो है कॉन्ट्राइंडिकेटेड होती हैं। इन लैब बेस्ड वी कैन आइदर मेंशन, जैसे कि हम इलेक्ट्रोलाइट रिप्लेसमेंट कर रहे हैं, पोटेशियम रिप्लेसमेंट कर रहे हैं, तो हम सीरम इलेक्ट्रोलाइट्स कराएंगे। व्हेन द पोटेशियम रीचेस विद इन द लेवल, विद इन द रेंज, तो फिर हमें वो स्टॉप करना होगा। देयर आर मल्टीपल एंटीबायोटिक्स जिनके लिए हम कराते हैं, जैसे वैंकोमाइसिन हो गई, तो वैंक के AUC की बेसिस पे हमें एडजस्ट करवानी होगी। IV to peroral switch में when the patient has been stabilized in an inpatient setting, तो हम IV ड्रग्स को peroral पे करा देंगे। अगर कीमोथेरेप्यूटिक की बात करें, तो अगर रॉन्ग कीमो प्लान है तो वो मेंशन होगा। दिस इज जस्ट अ इनसाइट, आई एम नॉट गोइंग इनटू द डेप्थ, आई एम जस्ट टेलिंग यू देयर आर मल्टीपल डोमेन्स जहाँ पे फार्मासिस्ट इंटरवीन कर सकता है। Now, here I've listed the 10 steps of CMM. We need to understand the patient personal medication, experience, history, preference. As I've already told you, कि proper SOAP note के through हम patient profile reduce out करेंगे. Then we'll identify all the patterns जो कि medication उससे मिल रही हैं, OTCs, prescribed, unprescribed medication. और फिर each medication को हम properly assess करेंगे कि इसकी क्या side effect है, कोई ADR तो नहीं है, interaction तो नहीं है। फिर हम थेरेपी की प्रॉब्लम को आइडेंटिफाई करेंगे, प्रॉपर केयर प्लान बनाएंगे और इंश्योर करेंगे कि पेशेंट उस पर पूरा उतरे और प्रॉपर अच्छे से फॉलो करे, एंड देन विल डॉक्यूमेंट इट। अगर इन पेशेंट सेटिंग की बात की जा रही है तो हम जो है अपना फार्मासिस्ट नोट डॉक्यूमेंट करते हैं। अगर आउट पेशेंट की बात की जा रही है, जैसे कि कम्युनिटी फार्मेसी में कर ले, तो वहाँ हम पेशेंट को अच्छे से काउंसिल कर सकते हैं, समझा सकते हैं, एंड फीडबैक मैकेनिज्म कर सकते हैं कि आप उनसे पूछें कि भाई आप हमें बताएं, जो हमने आपको चीज बताई है आपको ये समझ में आ गई है, आप किस तरह से लेंगे, तो फीडबैक मैकेनिज्म किया जा सकता है। Now what I would like to say that you need to get off the bench and into the zone. You need to get your skin into the game. ये कहना कि हाँ फार्मासिस्ट का रोल नहीं है, फार्मासिस्ट नहीं है, that's not up to the mark. You need to learn, आपको सवालात पूछने होंगे, आपको अच्छे से चीजों को काउंसिल करना होगा, और आप खुद अपने लिए स्टैंड ले सकते हैं। When in an inpatient setting, ये मैं अपने एक्सपीरियंस से खुद बताऊं, that when I went to my first clinical round, the question I was asked was कि फार्मेसी होती क्या है, फार्मासिस्ट ने पढ़ा क्या है। तो डू नॉट गेट डिग्रेडेड बाय सच क्वेश्चंस, यू नीड टू लर्न। और फिर आप जो है पेशेंट से पूरा सवालात पूछें, प्रॉपर रिकंसाइल करें। मल्टीपल टाइम ऐसा होता है कि डॉक्टर्स को हिस्ट्री नहीं पता होती, कभी कभार पेशेंट बताना भूल जाता है अपने OTC ड्रग्स जो उन्होंने लिए होते हैं, और उसकी वजह से थेरेपी का सही इफेक्ट नहीं आ रहा होता है। तो रिकंसाइल, एंड फर्स्टली नो योर ड्रग्स, यू आर द कस्टोडियन ऑफ ड्रग्स। तो पहले आप अपनी दवाओं पे कमांड हासिल करें, देन मूव टुवर्ड्स कोरिलेटिंग ऑफ द ड्रग्स विद द डिजीज। जब आपको ड्रग्स के बारे में पता होगा कि व्हाट बेसिकली आर द मेडिकेशन जो इन्हें प्रिस्क्राइब की गई हैं, उनका मैकेनिज्म क्या है, उनका ADR क्या है, उनके साइड इफेक्ट क्या हैं, क्या क्या इंटरेक्शंस आ सकते हैं, देन यू लर्न टू कोरिलेट इट विद द डिजीज। और हमेशा इस तरह से पढ़ें, जैसे फॉर एग्जाम्पल एक पेशेंट है, उसके LFT कॉम्प्रोमाइज है, ठीक है, अब वो UTI की कंप्लेंट से आया है, आपने उसे नाइट्रोफेरेंटाइन डॉक्टर ने प्रिस्क्राइब किया, तो इट शुड क्लिक इन योर माइंड दैट द LFT इज डीजेनरेटेड, यू कैन नॉट गिव हिम द नाइट्रोफेरेंटाइन, आप उन्हें ऑल्टरनेटिव बताएं। लाइकवाइज अगर OPD की बात की जाए, तो अगर आपके पास कोई पेशेंट आया है, आपसे आयरन सप्लीमेंट लेने आया है, तो यू शुड नो कि इसके साथ जो है आपको कौन सी चीजें नहीं देनी है। जैसे आप काउंसिल करेंगे कि भाई आप कोई भी जो है डेयरी प्रोडक्ट इसके साथ में। लाइकवाइज जैनब ने वारफेरिन की एग्जांपल दी थी, अगर पेशेंट वारफेरिन पे है तो नो दैट यू नीड टू काउंसिल द पेशेंट कि आपको ग्रीन लीफी वेजिटेबल्स नहीं है। Likewise, you need to understand all these stuff, and then you can get the insight about how to adjust and monitor proper comprehensive medication management. I hope you have gotten the idea to do so. In the end, I would just like to end my slides by saying it takes effort to win the game, but take courage to change the game. You need to be very courageous. You need to have command on your medication. Then only you can do better for the patients. Thank you so much. That's all from my side. If you have any questions, do let us know.
Thank you so much, dear speakers. We are deeply grateful for your participation and for sharing your knowledge with us. Thanks to all the participants for joining us today. Let's take some questions now from Dr. Zainab. The first question is, how can we know that nebulization is needed or not? Can you please answer that?
Yes, sure. It actually depends on the status of the patient, that whether the patient needs bronchodilation or not. You have to look for the history of any COPD or asthma, or like you'll have to review the patient that whether he needs nebulization or not. Like when in nebulization, we're actually giving the patient a bronchodilator. We give steroids and ipratropium or salbutamol. So we're trying to give the patient bronchodilators. So review the patient and look for the need of a bronchodilation. So this is how you assess that whether the patient needs it or not. Like look for the respiratory rate, the oxygen requirement, and review the patient appropriately.
Okay, thank you. So let's move on to the next question. Uh, how will we monitor the drug levels in the blood?
It varies and from drug to drug. For example, if you are doing the TDM for vancomycin, you'll have to follow the protocol that is given for vancomycin. That for vanc, we send the levels before the fourth dose, before 30 minutes prior to the fourth dose. In case of aminoglycosides, you send the peak levels and the trough levels. So it actually varies from drug to drug, and you have to read the protocol of each drug whenever you're giving the therapeutic drug monitoring. As I already mentioned, that it is another a very big topic and it is another big subject. So maybe I won't be able to give the complete details, but I can tell you that you have to look for the individual drug and look for the protocol of that drug. Many of the labs in like our hospital, it does check for vanc levels, but it does not check for voriconazole level. So we send the labs outside to Chaptai or some other lab, for example, at Shokathanam. So TDM, it varies from drug to drug.
Yeah, people are asking that where we can see all this knowledge of TDM, and please share and inform about the link of TDM monitoring. So yeah, these are the questions from you.
Okay. Okay, I'll look for some good reference and then I can share it.
Okay, thank you. From Dr. Mashal, uh, the one question is there that PPIs को किसके साथ change कर सकते हैं?
We can change this to famotidine.
Okay. Thank you so much to our speakers. And thanks to Dr. Mohammed Siddiqui for organizing this amazing webinar today. Handing over to you, sir.
Oh, you can go ahead and conclude, Janat Fatma. You are the moderator, so it's okay. I don't need to say anything.
Okay. Thank you so much for all the participants for joining us. So you can fill out the form or feedback form so that you can receive your certificates. Ending this session.
Allah Hafiz.